In conventional angioplasty, it is only necessary to insert a single sheath to access the vessel that is to be treated, and this is usually done through the right radial artery, which is the artery at the patient's wrist. In treating a chronic total occlusion, it's usually needed to insert two sheaths, one to provide access to the blocked artery and the other to access the other artery which feeds the blocked territory backwards through small communicating vessels called collaterals. Here we see both a radial sheath and a second sheath being inserted into the femoral artery, which is the artery at the top of the patient's right leg. Both sheaths are flushed with saline, which is salty water, to stop clots forming within them. Here you see the manifold being set up so that both pressure can be monitored and contrast injections given intermittently during the procedure. These images show the blocked or occluded segment of the right coronary artery. Injections into this blocked artery, which we call anterograde injections, can't show the extent of the blockage alone, as no contrast can transverse this blockage. In order to see the far side of the blockage, contrast needs to be injected into the opposite coronary artery, and it flows into the collateral vessels to the other side of the blockage, which can therefore be seen. The only way to treat a blockage like this is to pass a fine wire through and out to the other side, so that it sits in the vessel beyond the blockage. On this wire, it's then possible to pass equipment to enlarge the fine tract created by the wire until it's large enough to be treated by inserting a stent to scaffold the artery wide open and so restore normal flow and relieve the patient of angina symptoms. Now, there are two ways to cross this blockage. One is to push the wire through the material in the middle of the vessel, and the other is to cross into the wall of the vessel and create a track in this tissue plane before re-entering the vessel lumen on the other side of the blockage. This is called a so-called dissection and re-entry technique. In addition, either of those two techniques can either be used moving forwards through the blockage, called anterograde, or moving backwards from the feeder collateral vessels, called retrograde. You can see here that the operator is trying to use a special wire to find the original channel of the vessel in a forward or anterograde direction. Every so often, contrast injections are made into the opposite artery so that the backfilling of contrast allows visualization of the target at the other end of the blockage. This special wire is supported by a fine slippery tube called a corsair, which will be used to help dilate the channel formed by the wire if that wire does successfully manage to cross the occlusion. The wires being used have very special properties which are designed to maximise the chance of the operator being able to steer it successfully through the blockage. Here you can see the wire has made good progress, but it appears to be in a small side branch, and so is brought back into the corsair and further attempts are made to probe the blockage. The wire now seems to be potentially in a good position, and retrograde injections into the feeder vessel are used to see if the wire appears to be in the true lumen on the other side of the blockage or whether it's in a side branch. In this view, it looks encouraging. Here, however, it can be seen that the wire is actually in a side branch and not in the main vessel. So the wire is brought back and further attempts are made. with much manipulation, and after quite a long time an alternative path is eventually found which does appear to be in the correct place, and this is confirmed with injections from the retrograde vessel, which shows the wire is now sitting in the true lumen of the vessel on the other side of the blockage. Now that the wire is across and confirmed with a retrograde injection, the operator will attempt to advance the Corsair to dilate up the track. Unfortunately, the Corsair fails to cross, and you can see the guiding catheter being pushed out of the origin of the coronary artery as the force is applied. Sometimes what has happened is that the slippery coating of the Corsair has worn off, and the operator on this occasion is going to change this Corsair for a fresh Corsair. There are other alternatives, such as using laser wires to try to create a channel. You can see here the fresh Corsair being gradually advanced over the wire and passing the occlusion, and with much pressure, with the guide catheter backing out slightly, the fresh Corsair does eventually manage to cross the hard material of the occlusion. Gradually and slowly, the device is advanced through the blockage. It's now possible to remove the specialised wire and replace it with a safer supporting wire, which you will now see being advanced through the Corsair, which sits across the occlusion, and into the distal vessel. The Corsair is now removed, and the channel that it has created is now wide enough to allow an angioplasty balloon to be inserted and inflated, so widening the channel with progressive dilatations. Here you see a balloon in one position inflated, and here you see it being inflated in another position. And in another position. So opening up a channel around the wire. With enough space around the wire, a stent can now be positioned. Here you see the stent being advanced, visible as a grey line between the two dots at the beginning and end of the balloon. The position is confirmed with a contrast injection, and when the operator is happy as it is in the correct position, the balloon over which the stent is crimped is inflated, and as it inflates, so it pushes the stent material out and scaffolds the artery. A second stent is implanted in a more proximal position. This is now dilated, opening up the stent struts and again scaffolding this part of the artery. For the first time, forward or anterograde flow is restored into the artery and allows visualization of the more distal vessel. This reveals that beyond the first stent that was implanted is an area of diffuse disease which will require further treatment. A different view shows this diffuse disease more clearly. The operators will now attempt to pass a stent through the first two stents into this segment. As they try to do this, you can see that the guiding catheter gets pushed out and all the equipment falls out into the aortic root. Fortunately, as the vessel has been stented open, it's quite easy to re-engage a new guide and re-advance a wire down the vessel. Here, the area that was causing the equipment to snag has been dilated to try to allow easier passage of the equipment. A new guide is inserted and a fresh wire is passed through the guide and back into the vessel, through the new stents and into the distal portion. You can see it's now possible to advance the third stent into position where the distal disease needed to be treated. You can see contrast injections confirm that the stent is in the correct position in this vessel. And now that stent is deployed by inflating the balloon over which it's crimped. The stent is now deployed. The balloon is then deflated and withdrawn. Finally, all the balloons and wires are withdrawn and an angiogram shows excellent forward flow into the reconstructed right coronary artery, supplying a large number of important branches to the patient's heart muscle, which it is hoped will cure the patient of his symptoms of angina on exertion.